All right, so our first panel of the morning is Understanding NMOSD and MOGAD, Clinicians' Perspective. So we are very lucky to have four incredibly knowledgeable and inspiring clinicians up here. Would you please introduce yourself? So who are you, what institution are you from, and why do you do this work?
Good morning. It's a pleasure to be here today. Welcome to everyone. I'm Esther Melamed. I am a physician scientist. I practice at Dell Medical School at UT Austin. And just as Dr. Greenberg said, it is always so invigorating to be together at events like this and to meet each other and to have really honest, candid and inspirational conversations about how we can move NMO forward.
Thank you.
Hi, good morning. I'm Lauren Tardo. I am a physician at UT Southwestern with Dr. Greenberg and Dr. Blackburn. I'm happy to be here today, and the reason I do this is for the patients. It's a very wonderful, wonderful patient population, and I get a lot of joy in helping my patients.
My name's Kyle Blackburn. I'm one of the faculty at UT Southwestern, and the reason I do this is I've always had a very strong interest in offering clinical care to patients with rare autoimmune diseases beyond multiple sclerosis, so I've wanted to build a clinical home for them.
Hi. I've already been introduced.
But why do you do this?
Why do I do this?
Mm-hmm.
So the history, the honest answer of it is, when I was going to medical school, I never thought about neurology. It wasn't on my radar at all, and then fell in love with it during medical school. And one of the things I really was excited about was the fact that there were so many unanswered, but I felt answerable questions. And then when I got into neurology, I really felt like neuroimmunology, autoimmune disorders of the brain and the spinal cord, really encapsulated that these were conditions that were going to be cured, that were going to find treatments. And I thought it would be amazing to try and play a small role in that process. And along the way, I think, Lauren, you said it best, the patient populations, especially in rare disease communities, are a very unique group of individuals in terms of the very different interactions we have with our patients versus more common diseases, where we're learning, again, just as much from you as you are from us. And so that brought me to this point of, like Esther, being a clinician scientist, spending some time in research, some time in the clinic, but loving both worlds.
Thank you. I have to say that really the only world I know in terms of rare diseases is NMO and MOGAD. But what I do know is that this community is so lucky to have such dedicated clinicians. And it wasn't until I started going to these medical conferences a few years ago where I stopped being scared about our diseases, because I looked around and I was like, wow, there are a lot of doctors who really, really, really care about these diseases. And I don't think that they are going to give up on us. And I think you guys continue to prove that, research is incredibly important. You're so dedicated to it, doing things like this. Like, the dedication from the clinicians in our community is outstanding. And I think we are so, so, so lucky to have doctors like all of you. So thank you. So a lot of our audience, may have just gotten newly diagnosed. And as you know, these diseases have a lot of really difficult jargon. So if I can call on one of you to just give a very simplified definition of, let's start with, what is NMOSD? Dr. Tardo?
Yeah. So NMOSD stands for neuromyelitis optica spectrum disorder. It can be a mouthful at times, but it's an immune-mediated attack to part of the nervous system. Specifically, really likes the optic nerve spinal cord, which is why a lot of times our patients present with vision complaints, optic neuritis, or transverse myelitis, which is a fancy term for inflammation of the spinal cord. And so that's a very simplified definition, but I think it kind of breaks it down in an understandable kind of way for patients.
Okay, thank you. And Dr. Blackburn, what's MOGAD?
So MOGAD is a more recent discovery, and it was really, I think we've known for many years, many people have this phenotype that looks like neuromyelitis optica. They have that optic neuritis and that transverse myelitis that we're talking about, but they tested negative for aquaporin 4. And MOG has been one of the first antibodies to kind of define that population. And so patients with MOG, whenever they come to the hospital, it may be very difficult for most of us to tell them apart from a patient that may have NMO. And really having these antibody tests has made that very critical. And what we've learned over time is, at first we may have been classifying some of the MOG patients as having a type of NMO, but they behave very differently. And because of that, it was very different to separate them. So MOGAD patients can have distinct features and distinct outcomes. So we've now defined these diseases as its own entity.
Thank you. Dr. Melamed, am I saying that right? Okay, Melamed. It's kind of like my last name. Mine's Ahmed, so Melamed. Okay. What are the basics that people should know about NMO?
So, as it's already been said, this is a neuroinflammatory condition, meaning that the immune system will go on either due to a genetic predisposition or environmental factors. We're still learning about what causes diseases under the umbrella of NMO spectrum disorder. But at some point, there may be a breakdown in the barrier called the blood-brain barrier, which separates the blood compartment from the brain and spinal cord compartments. And the immune system is allowed to come into the brain and spinal cord space. And the antibodies that we've learned about over the last decade and continuing to learn about other types of antibodies which may be potentially part of this disease for patients who are seronegative, participate in this very preeminent attack on brain proteins. So either on myelin-related proteins or on aquaporin, depending on which antibody is involved. And there is, when this attack happens by the immune system, it leads to damage in the brain or spinal cord or optic nerve, leading to the symptoms that we observe in patients.
Dr. Greenberg, I have two questions for you. The first is, what are the key recent developments that get you excited about NMO and MOGAD?
So this is going to be a long answer.
Perfect.
So I'll break it into two categories. So one is, if you look at the history of rare diseases around the world, the path to getting FDA-approved therapies has been traditionally an incredibly long and complicated path with very limited numbers of therapies becoming available. And in what was essentially a very short period of time, historically speaking, we went from understanding neuromyelitis optica in terms of the biology to having 3 FDA-approved therapies to treat the condition. This is unheard of in rare diseases. And I think you're about to see the exact same thing in anti-MOG associated disorder. And we'll talk about trials in a bit. And so that rapidity with which we got a diversity of therapies is very unique to this set of conditions, largely because of the community that's been formed, which has been very tight and very organized between patients and caregivers, industry, universities, research labs to really move things along. The second area of science that I find most exciting is on understanding the underlying biology. You really can't cure a disease until you understand its biology. It's just not possible. And so the level of sophisticated science that's going on to understand how and why an immune system gets confused the way it does is reaching a really exciting point. And the discussions that are happening now, we had only dreamed of 10, 15 years ago. Discussions around, can we actually, in the not too distant future, retrain an immune system without suppressing the immune system? Can we get to a point where we get rid of these antibodies that we talk about without the friendly fire of taking out the rest of the immune system that's so valuable to us? So I really think where we've gotten to is amazing, but where we're going is even bigger.
How different is the conversation that you have with newly diagnosed patients now versus, let's say, 10 years ago?
Yeah, so am I the oldest one here? I guess I am. All right. Damn. 10 years, I've been having these conversations. So I have now officially been having these is the bar open? I've been having these conversations for 20 years now. It's actually hard to believe it. And when I think about the 10 and 20-year arc, it's really incredible. I started in this field before the anti-aquaporin 4 antibody for neuromyelitis optica was identified. So for years, I was treating patients with the disease, and I didn't know what was going on. And then we started to understand the biology. And so the two, I say 3 breakpoints in the evolution of the discussions I've had were pre-understanding the biology, and it was a very scary, sad conversation because there was not a lot known. Once we got an understanding of biology in a much better way for neuromyelitis optica and started using therapies in a more meticulous, albeit off-label fashion, global immunosuppressant medications, we really turned a corner. We started to see our patients do so much better than in the years prior. And then we get to what I'll call the modern era of approved therapies for NMO and hopefully soon to be approved therapies for MOGAD. And it's a night and day conversation. We used to quote statistics about 33% fatality rate from these diseases over 10 years, a 50% rate of blindness or quadriplegia over 5 years. We are not seeing anything close to that. We don't talk about fatality in the clinic. We talk about morbidity, but not fatality. And even on the morbidity side, the majority of my patients, when diagnosed early and started on treatment early, are doing extremely well. And the conversations have shifted much more into quality of life and symptom management. And a lot of the things our patients deal with under the surface, but thankfully we're not having to have the bigger conversations about global function and survival. So it's been great, but we still have more to do.
Anyone else?
Yeah, I'll just add briefly that it's been really, really invigorating to start to understand the pathophysiology and what is causing the disease. We're still in the very early stages of this. There's still so much to learn, especially for patients who are seronegative for the disease. But it's really made the conversations change from you look like you have multiple sclerosis to we actually think that you might have an antibody that is responsible for your disease. And that has also changed the conversations in terms of treatments, because now we know that some of the medications that treat multiple sclerosis may actually make NMO spectrum disorder worse. And it's really important to have that understanding so that we can treat each patient individually, as opposed to treating them as someone who looks like they have neuroimmune condition and will throw any medication at them that we know works in diseases like MS. So it's really been a game changer to be able to have a specific diagnosis and to continue to improve on our diagnostics with the research that's very heavily ongoing.
Thank you. I want to debunk a couple of myths, or hopefully. Is it possible to have MS and NMO or MS and MOGAD?
I don't mind taking that one. I think
Good.
in my opinion, that's probably highly unlikely, maybe an exceptionally rare thing, and I would say probably doesn't happen. The aquaporin 4 antibody really does define, and this has been shown over several years, that aquaporin 4 is defining a very unique subset of patients that meet that NMO criteria and look very distinct from MS. In the MOGAD world, there's a little bit of interpretation required in the results. So there are patients who have multiple sclerosis that may have a lower level of a MOG antibody, and I think that story is still evolving, but a lot of people argue if it looks like multiple sclerosis in those patients, to continue to treat them as multiple sclerosis. But still, whenever we look at people that have the features that have now been labeled as MOGAD, those patients tend to have a very different course and treatment profile compared to multiple sclerosis. So I hope everyone here agrees, but I think they're really distinct, and it would be exceedingly rare to see them commingle.
Okay. And then the second, Unfortunately, this information still exists on the internet. When you Google NMO, one of the first things you see is that you have 5 years to live. Dr. Tardo, is that true?
No.
Okay.
And I think it goes back to what Dr. Greenberg said in terms of how the landscape has changed so much over the past few years and really kind of rapidly evolved. And I think these conversations are very different now, and we need to change that message because it's not the case.
And what is the mortality rate, if there is one? Do we have a number that's current?
I would say we probably don't have an updated number, but I would say it's very, very low, especially in those patients that are getting on appropriate therapy at diagnosis. I think we're seeing our patients, probably way outlive whatever statistic I could throw out there, because again, it's just a different landscape now.
Okay, that's good. Shifting gears a little bit, so Dr. Greenberg, obviously a lot has happened in this space over the last 20 years, and I'm asking you this because you're an OG, but what do you think still really needs to be done? Like, what's a huge barrier from a clinician's perspective that would further change the game for the better?
So I think there are many challenges still ahead. I think we've done an amazing job in improving diagnostics, and we've talked about the therapeutics, but I still, as I mentioned, believe these are curable conditions, and it's interesting when I need to be careful. I've had patients over the years come in and say to me, when is this going to be cured? When is there going to be a cure for any of the diseases that we treat? And I always turn it around on them and say, well, what do you mean by cure? And I get usually one of three answers. So one is, I go on a treatment, some sort of treatment, and I know with certainty I will never have another event, period. And I'm not worried about the future. That's answer one. Answer two is, I take one dose of one medicine once, and then I never have another event again. And then answer three is, I want either number one or two and something that reverses all of the prior symptoms that I have. And so everyone has a different definition of cure. If we start with that first definition, which is kind of that first step, I think we're headed there. I think we're headed to having medications where I can look patients in the eye and say, you're never going to have another event. You need to stay on this or that, but you're never going to have another event. And I think we're knocking on the door of number two. We're doing studies right now at Southwestern, and I know, Esther, you have experience with bone marrow transplants in multiple sclerosis, and the data there says 80–90% of those patients a decade out on no medicine have had no new events. And so is that a cure? I don't know exactly yet if it's a cure. And then we've launched studies to repair damage that's been done. Some of them are drug studies, some are stem cell studies. So we've got work happening in all three areas, and all three areas have need. And so those are the areas that we're looking towards. I would love, and there's going to be a panel later, so I won't speak to it, but to also, in the meantime, while we're doing all this great work, get better at symptom management and get better at improving quality of life based on scars that were left behind. But I think we're going to see advancements on both sides.
Fab. Okay, Dr. Esther, I'm going to call you that because I don't want to keep messing up your name. MS, the patients in our community are oftentimes misdiagnosed with MS. And obviously that's a huge problem because the therapies are different. What can we be doing as a community to decrease that misdiagnosis rate? Like what more needs to happen?
So a lot of work has already been done in order to spread the message about NMO, and the time to diagnosis is a lot faster, but it also depends on the community. NMO spectrum disorders are not just a disorder that affects people in any particular geographic location. This is a disease global. This is a global disease. And in some communities, it continues to be challenging to get to a test. Depending on what test is done, the test may be positive or it may be negative. And it's very important to be able to interpret the result and to understand for the patient who's getting that test, exactly which test was done, and what does that negative mean? Is it a true negative or is it a false negative? And what other diseases should be checked in order to get to a final diagnosis if that test is negative. So that starts the conversations with between the patient and the clinician in terms of what is my diagnosis. And when an antibody is positive, and it's usually if it's positive, it's a true positive for aquaporin. MOG can be positive in a number of different conditions, not just as a neuroinflammatory attack as we think of MOGAD, but it can actually be positive in patients who have epilepsy or in patients who have had a stroke. This antibody can actually be positive across different neurological conditions, and so the interpretation of that test is important as well. But at the initial visit, it is so important to have a broad differential diagnosis of the neurological symptoms in order to differentiate from multiple sclerosis based on the blood tests, based on the imaging data, and based on the history of the patient. We know that patients who have NMO spectrum disorder often can have other rheumatological conditions, for example, and other systemic symptoms that may clue the clinician into this being more along the lines of NMO spectrum disorder, seropositive or seronegative. But it's really important to approach it from a deeper, sort of thoughtful perspective in order to differentiate MS from NMO spectrum disorder and from other neurological conditions.
Perfect segue to my next question, which is really selfish question. But for us double seronegative patients, when should we be testing? When should we be asking our doctors to test? Like, what does the future look like for double seronegative patients? Because, being double seronegative poses its own set of challenges. Access to therapy is incredibly challenging. Even a bit of an identity crisis, I would say, because you're like, do I have NMO? Do I have MOG? Do I have MS? Like, what do I have? So any thoughts, any ideas?
Yeah, I'm going to launch, but I actually want everyone to comment on this because I think this is really confusing for everybody. I can't see anybody. These lights are really bright. So if I ask for a show of hands, I won't know if anyone's raising their hand. But when we talk about antibody tests, I was going to ask how many people here are very comfortable with what that means, and most people are very uncomfortable. And I think it's helpful to understand, I'm going to geek out a little bit about the science of how we test for antibodies, because it's going to help you understand why we have these conversations. So the human body has the potential mathematically to develop 1 quintillion different antibodies, a huge diversity of antibodies. And you have antibodies against flu and antibodies against COVID and antibodies against strep and measles. And the antibodies themselves, these little tiny proteins, are like the super smartest smart bomb in the history of the world. So it's the equivalent of me launching a missile or firing a gun here in Dallas, it traveling to Paris, France, and finding the one guy named Joe and hitting Joe and leaving everything else intact. That's a phenomenal capability. They're supposed to be very specific for their target. So no matter where they're launched, they're always going to land on their target. And so in immunology, we like to test for antibodies. It turns out, so if you're interested in testing for antibodies, weapons against Joe, there's actually like 100 different versions of a bullet that might hit Joe. And I hope no one here is named Joe. And about 20 of them may hit Joe. Nobody's named Bartholomew anymore. Or Bartholomew, it's a safe name. And so if I put in a dish a bunch of copies of Bartholomew in, I may get some of Joe's bullets by mistake sticking to it. And so what we do is we literally put proteins in a dish or proteins in a cell, and we take your blood, mix it together, and we see what sticks. And some of the tests are better than others. Not every test is made the same. Not every lab is the same on how they do the tests. And so it can be very confusing when you go to one doctor and they say you're negative,
And then you go to Dr. Blackburn and he says, well, that's not a real negative. Let's repeat the test and it comes back positive or vice versa. So to your point, when we have patients who are testing negative for both antibodies, the anti-MOG and aquaporin 4, I think we all start with the question of where were you tested, how were you tested, and when were you tested? And even using the best science available, there are people who will test negative for both antibodies, but clinically have the condition. So it leaves the question, what the heck's going on there? Esther and I collaborated, I guess it was a couple years ago now, with the team in Austin who does just amazing science. And we were able to take blood samples from patients who had tested negative for both of them multiple times over. And then at the level of the cells that make the antibodies, basically the gun that fires the bullet, we were able to show they had anti-aquaporin 4 antibodies. They had cells that could make the antibody. Even though we couldn't find that bullet in the blood, we found the gun that fired it. So we knew that the assays just weren't picking up those antibodies. So I think the science is going to evolve to better testing over time, but it still leaves the here and now. So I got to just geek out. I'm going to have these guys give the hard answer, which is, what would you tell someone who's tested negative more than once on high quality assays? Is it worth repeating over time? Have you had people who surprise you with a positive at some point?
Well, it's an interesting question. Sometimes I have had that happen, and so there's a lot of caveats to antibody testing, and we're going to back off from the war on Joe for a second, so you guys can everybody be at ease if you're Joe. But we've had patients come in specifically if they've been recently treated for a relapse, and in those settings, I think some of the therapies you may have heard about plasma exchange, those therapies pull out antibodies. That's one of the primary ways they work. So you can be what we call falsely negative in that period. So if the testing doesn't line up or there's uncertainty, and I'm looking at someone and I'm like, this looks like NMO, and I'm not going to believe it until otherwise, I will often repeat that test. I think it's definitely important in people who, again, when an experienced doctor is looking at it and saying, this just looks like NMO, looking at the imaging, looking at the history, there's this response to treatment, that we are considering testing them at a certain time point. Maybe that's not 10 years of testing. I can't say that I can recommend that, but I certainly think at least doing a repeat test at 6 to 12 months would be reasonable if someone's looking at it and saying, this just looks like what we would see in NMO or MOGAD.
And I would have to agree. I think that I practice very similar to Dr. Blackburn. Looking at where the test came from initially, then deciding if it should be repeated, looking at the treatments that were given in the acute setting, and then again at 6 months, if I'm convinced, I generally always recheck, and then sometimes I'll check again at a year. And then even then, sometimes if it's negative, it's a difficult conversation, but I think I tell my patients, something is clearly going on. The science just hasn't caught up to you yet. Mm-hmm. It's going to catch up. And just reassuring them that we are still, looking for answers.
Yeah, and I would agree with everything that's been said. It's always important to not leave any stone unturned, to understand what kinds of assays have been done. Some are better than others, under what conditions people were tested, and sometimes it may take time to develop a positive antibody. Some studies have suggested that it may take up to 10 years to develop positive antibodies. So it's, I would test probably every year for the first 5 years, but make sure that other workup has been done in order not to have missed another neuroinflammatory or neuroinfectious or neurovascular diagnosis that could cause similar patterns on the MRI and cause similar neurological symptoms.
So symptomatic, double seronegative patients should be on therapy, correct?
Oh no, this one's all you.
Why is it all me? Anyway, I think people who we're fairly convinced with a reasonable certainty who've had a good, thorough rule out of other causes and are double seronegative we're convinced they have some sort of inflammatory disorder, even if the testing hasn't panned that out. We will typically use some sort of maintenance immunotherapy to try and prevent relapses, and I think that's probably safe to say.
Yeah, I would agree. And you have to really, in those patients, you have to be careful with the therapy that you choose. And so generally we take a broad approach in those patients, but I would agree.
Okay, let's talk numbers. What is the most current prevalence rate? I hear things all the time, so I want to know from you guys, like, what is the prevalence of NMOSD and what is the prevalence of MOGAD in 2023?
Yeah, it's interesting. For NMOSD, it depends on where you live. So if you look through the world, there are certain areas that have a much higher prevalence than in the United States. So if you look in Afro-Caribbean communities, I just was at a research meeting in Brazil where if you're a neurologist in Brazil and somebody presents with inflammation of the optic nerve, the optic neuritis, so they come into the clinic with blurred vision and pain in their eye, it's more likely to be NMO than MS in Brazil, and it's the exact reverse in our population. And so depending on where you live, these numbers change dramatically. They can be anywhere from 1 to 10 in 100,000. No matter where you live, even if NMO is more prevalent than MS, it's still a rare disease if you look at the overall populations. In the US, the estimates that keep getting batted around is somewhere between 10 and 15,000 patients in the United States with neuromyelitis optica. And that shifts a little bit once we started moving some patients into the anti-MOG associated disorder diagnosis. The other thing that changes in terms of prevalence is based on age. So I see both adults and children with these conditions, and it is exceptionally rare to have a child, a prepubescent child, so under 12, 13, with anti-aquaportin for neuromyelitis optica. Exceptionally rare. It is very common to have kids with anti-MOG associated disorder, much more common. And so depending on how we parse the population, these numbers change quite dramatically. Compared to MS in the United States, the number I throw around is probably about 2% of the population. So if you have 100 people with multiple sclerosis, there's probably somewhere around 2 with either NMO or MOGAD.
What about worldwide?
Worldwide, we have better data in some places than others. So the best data, Europe is very similar to the United States in terms of that breakdown. If you go to Asia, Japan, and Southeast Asia, the number of neuromyelitis optica patients relative to MS goes up significantly. So I was about to say old textbooks, but textbooks are old anyway. You guys never even used a textbook. So in the stone tablets in Sanskrit that I would read in medical school, there were discussions of something called opticospinal MS in Japan. So it was patients who had been told they had multiple sclerosis, but it was only affecting the spinal cord and the optic nerves. Sound familiar? And over time, it was discovered that the overwhelming majority of those patients were neuromyelitis optica and then a subset of anti-MOG. And so if you go to Japan or in an Afro-Caribbean community, that 1 to 2% easily goes up, maybe even to 10%, 10 out of 100 or more.
What about gender breakdown?
Yeah, so I can speak to that. There is a predominance of females diagnosed with NMO spectrum disorder, up to 9 to 1 female to male ratio. There is a predominance of other autoimmune diseases that can be part of NMO spectrum disorder, and autoimmune diseases certainly do have a predilection for females in terms of prevalence. But we also have learned that when men develop NMO spectrum disorder, it can be a lot more of a severe presentation and disease over time.
I've definitely seen that too. I've observed that in our community. Okay. To hopeful things now. I believe in January, the International Diagnostic Criteria was published for MOGAD. Can you guys speak to that? What does that mean for this community? Is that considered a breakthrough? Is that going to save lives? Just any thoughts, opinions, comments on it would be great.
Yeah, I'll take this one. Yeah, I think that was pretty revolutionary for our world, just in terms of helping us differentiate these patient populations. I think, if somebody had a very high, MOG antibody titer and, clinically fit, it made a lot of sense, but there's some gray area there in some of these patients who may not have a high titer but clinically look like it. And so helping us differentiate where they fall, and if we think it's consistent with that, I think has been huge in terms of helping us, determine, what is risk of relapse, what is, the need for treatment. And so I think it's been huge in this patient population. And I think it's going to be really interesting to see how things evolve further as more and more information comes out on how the diagnostic criteria affects kind of what we were just talking about, prevalence and things like that.
And a final, oh, go ahead, please.
No. And I'll just echo that. So, and I always like to emphasize this when I'm talking with patients that have these antibody-associated diseases, is it's not just having that antibody, it's does that antibody line up with what the majority of people in the clinical course have. So I think it's really important that we just don't say MOG antibody, this is now MOGAD, that we look at MOG antibody, does this fit these criteria? Does it fit the typical clinical course? And then we can apply that label. I think that level is certainly very important, and I emphasize that to everyone.
Okay. And one more question before we open it to the audience. From a clinical and scientific perspective, what are you each looking forward to?
So as a physician scientist, it always warms my heart to think about what is to come. Mm-hmm. I am particularly excited. So Dr. Greenberg talked about the really exciting areas of stem cell research. I am also excited about what we get to learn about the gut microbiome in NMO spectrum disorders. And the connection between the gut and the brain. I'm also super excited about some of the ways that we can prevent NMO with vaccines that are being thought about. So it's a very, very exciting area. I remember first meeting my first NMO patient over 12 years ago, and thinking to myself, my goodness, we don't have that much to offer. And as you had alluded to with your very first question, how have the conversations changed? And the conversations have changed significantly. And it's no longer a diagnosis of doom. It's a diagnosis where we say, yes, no one chooses to have a neurological condition. No one chooses to have an NMO spectrum disorder. But we have so much to offer at this point with 3 approved therapies and with so many therapies on the horizon. So I'm very, very hopeful that in the next decade, this disease and the treatment of this disease will look very different for patients.
Wonderful. Dr. Tardo?
Yeah, I would have to agree. It's the future. I'm probably the baby in this group. And so just even seeing how this conversation that I'm having with patients has changed from when I was a fellow to now in terms of the knowledge that we have, the treatments that we have, it's crazy, and it's very exciting to be a part of this. I always thank my patients for letting me learn from them, and so I'm very much looking forward to the future and where we're going. I also really am excited whenever I get to tell a patient that this is treatable and kind of seeing that sigh of relief, and so I'm looking forward to the conversation when I say there's a cure for this, because I can only imagine what that response will be, and so very much looking forward to the future.
Before I answer, I want to say I'm only a year ahead of training in Dr. Tardo, so she's not necessarily just the baby here. But the thing that I'm probably looking forward to the most is the advances in treatments that are coming, specifically for MOGAD, but even the advancement of treatment strategies for patients with NMO. So for MOGAD, we now have these clinical trials coming out, and hoping that they increase the recruitment here in the coming months and roll out, and that we will now have that high-quality evidence that we have for NMOSD. Even faster than we did for the aquaporin 4 people. And I'm also, beyond that, also looking to more excited about efforts to try and make sure more patients are getting access to these therapies appropriately.
I agree. And I'd add, so I think the preventative therapies are going to be just worlds different as we get 5 years from now and 10 years from now. But I really do see a huge explosion in the work happening on restorative therapies, on therapies to repair damage that's been done. And that's something that was science fiction when I started, but there are patients in trials now who are receiving therapies to try and repair the damage that's been done. So it's coming. It's always slower than we want and not as close as we want, but it is coming. And so one of the conversations I have with patients now is it's important to prevent new damage. It's really important to stay healthy in other ways, lifestyle, exercise, nutrition, sleep, stress management, all those things that make a huge difference, because the better we maintain our health now, the better a candidate we will be for those restorative therapies that are coming. So it really is a partnership as we do this together.
Lovely. Any questions from the audience? Live or virtual audience? Don't be shy. I can't. Hello. Is there a microphone for her?
I'm impressed you can see. It's just where I'm sitting.
Hello? So, I don't know if this is a stupid question, but
No such thing.
well, I don't know if they said something about the proteins cross the blood-brain barrier, and maybe that had something to do with the inflammation. Is there anything that would help close the blood-brain barrier if some people have more of a porous blood-brain barrier?
I'm not answering.
So I think I was the one that opened that can of worms. There is not a great way to measure if the blood-brain barrier is open via a blood test, but we can certainly see it when a patient gets an MRI of the brain, when contrast is injected into the blood, and if we see the contrast showing up in the brain or spinal cord, that tells us that the blood-brain barrier had to be open for the contrast to traverse. And we can monitor patients over time to see if the blood-brain barrier has closed, because they will no longer be able to pass the contrast through. And so we will not see a contrast-enhancing lesion. We will still see a lesion which signifies damage in the brain or spinal cord or optic nerve, but we will not see a contrast-enhancing image. So that's one way that we can diagnose. There are a lot of there's a lot of research to try to figure out how to close the blood-brain barrier. And for example, in multiple sclerosis, one of the treatments that's used, it actually prevents the entry of the immune cells in past the blood-brain barrier. There is no such treatment yet that's approved for NMO, but there's a lot of work trying to understand the proteins, the molecules that are at the blood-brain barrier that could be blocked potentially to prevent the entry of the immune system past that barrier. And this really brings up also another really interesting questions of where do the antibodies originate? Do they come from the periphery and therefore have to traverse the blood-brain barrier to get into the brain and spine? Or are they actually made inside the brain and spinal cord compartment? In which case then closing the blood-brain barrier wouldn't really help because they're already there. And there's ongoing research to try to answer that very, very critical question.
And I think we have time for one more question. In the back over there.
Thanks so much. So yes, we have some questions from the audience online. Can we take two or just one?
Yeah, let's do two.
Okay. So the first question is regarding treatment. The question is, how quickly should treatment begin after a diagnosis of MOGAD?
Sure. So a little bit of a complicated question, but I'll kind of answer it with two parts. The first is if someone is acutely having a relapse, and we feel very confident about that because we have evidence, they've had an acute decline that's new and they have MRI lesions, we try to treat those patients as soon as possible with some sort of acute immunotherapy like steroids or the like. For the patient that has MOGAD and is coming to us in the clinic and had their first attack, there may not be a need to initiate treatment right away. And this is one of the differentiators between aquaporin 4 and MOG. An aquaporin 4 patient that comes to clinic, I'm going to be having the immunotherapy conversation with them, the starting maintenance treatment pretty much from the get-go. The MOGAD patient, I may say, because there is a high proportion of patients that only have one event that we should observe. And if there is a second event that we're very clearly convinced happens, then we should initiate immunosuppression for a period of time at least.
One more. Thank you so much for the answer. I know the audience online really appreciates that. The other question is, can we ever get our vision back?
It depends, is just being completely transparent. So you can think of the optic nerve as a cable connecting, when we used phones with wires, there was a transatlantic cable connecting the US and Europe, and that cable had millions of individual wires in it. And that's kind of like the optic nerve. You have 1.4 million individual neuron wires connecting your retina to ultimately your brain. And each of those wires are insulated. If the lack of vision is due to a loss of insulation, but there are enough wires left behind intact, in the future we will be able to restore vision. If the wires themselves have been cut to a significant degree, that is a much harder piece of anatomy to restore function to. And so I think the first thing we're going to see is individuals getting vision back who had just lost the insulation around the wires. It's going to take longer to actually restore the wires themselves.
Okay. Well, as a person whose worst subject in school was science, I really appreciated all of you simplifying this very difficult, these very difficult diseases for me and the live and virtual audience. So thank you so much to all of you for joining us and for helping us understand NMO and MOGAD.
Thank you.
Thank you. It's nice to meet you. Bye-bye.
Sister?
Oh, let's do it.
I don't want to see any Aggie signs all.
Thank you. Okay, what's next? Michael, I'm looking at you.
So next we have
Managing NMOSD and MOGAD. Oh, this is a good one. Addressing symptoms and comorbidities. Paula Hardiman, please join us.